what's the definition of a definitive airway? It's an airway that's below the vocal cord, secured, cuffed, and hooked to an oxygen, meaning an endotracheal tube. That's what the definitive airway is. The supraglottic airways, such as an LMA, laryngeal mask airway, or the combi tubes, are not definitive airways. They're supraglottic airways. So when you're intubating a patient, when you're assessing a patient, when you're assessing their airway, you make sure that you keep C-spine immobilization. Okay? So let's say the patient that came in was alert, oriented, walking, talking, not walking, just talking, and doesn't have any of the signs that we just mentioned, doesn't have any signs of trauma to the face, is not having any stridor or hoarseness of the voice, and is talking to you completely fine. So we make sure that the patient has a C collar on and his C-spine is immobilized, and then we move to B. So what's B? It's breathing and ventilation. What do we do in B? It's basically a complete examination of the breathing status. So you want to inspect. What's the first picture up? Yes. What's it called? The belt marks, what are they called? Called seatbelt sign. But yes, these so these are signs that can be found on inspection, which is why inspection is very important, which reminds us that if a patient has clothes on, so let's say this patient came in and had the t-shirt on and we decided not to actually take the t-shirt off and not do a complete examination, we would have missed these belt marks. So this is why it's important to expose the patient. Okay, so we're inspecting for belt marks, injuries, bruising. We want to inspect for the position of the trachea. We want to make sure that it's midline, that it's not shifting to right or left because of a hemothorax or a pneumothorax. Palpation, what do we do in palpation? We're checking for any fractured ribs, and sometimes we it basically feels like you're touching bubble wrap. And it makes a crunchy sound. It feels like you're touching something that's actually crunchy. Okay, auscultation. We want to make sure that the patient has adequate air entry bilaterally. And we want to make sure that there's no signs of hemo or pneumothorax by decreased or absent air entry on either side or in one of the zones. Yes, you want to check for chest movement as well. That's in inspection. Okay, so what's the goal of breathing and ventilation? We want to make sure that the patient has no concerning features that are going to affect the ventilation of the patient, because we want to have prevention of hypoxemia, which is achieved through an unobstructed and adequate ventilation. This takes priority over management of all other conditions. So this is why A and B are very important. So if a patient has a simple pneumothorax and it's not managed, it can be converted to a tension pneumothorax when the patient is intubated or placed on positive pressure ventilation. Is that clear? And RR is respiratory rate. Because if the patient's breathing at 40 breaths per minute, that tells you that the patient is in respiratory distress and that there's something underlying going on. Clear up to this point? Okay. Last point of breathing and ventilation is what I mentioned earlier, is you want to make sure that the patient has a saturation that's acceptable. So technically acceptable is above 94%. Moving on, circulation and hemorrhage control. So what do you want to do in circulation and hemorrhage control? You want to do an assessment of level of consciousness. Is the patient altered because they've lost so much blood? Are they altered because they have hypovolemia? You want to assess the patient's skin, and you want to assess the patient's pulse, because one of the earliest signs of hypovolemia is tachycardia. So level of consciousness, skin, and pulse. You want to make sure that the patient doesn't have any bleeding sites, and if they do, you want to make sure that you give them IV fluids and or blood, and that the patient has control of the bleeding site itself. This is an example. So a patient has an injury to their right lower extremity and they have active bleeding, and he's placing a tourniquet on himself to control the bleeding distally. Does anyone know what this is? Okay, so this is a level 1. It's a level 1 infuser. This gives blood and fluids to patients at an extremely fast rate. So in under 5 minutes, you can give a full unit of blood in this machine instead of the typical IV bag, IV pole, and pressure. So this is extremely useful in patients who are very hypovolemic and require large amounts of replacement of blood and or fluids. Okay, disability, we've talked about this. So GCS and pupils. What's GCS? Glasgow Coma Scale. Eyes, four components, meaning V, which is the verbal, which is 5, and then the motor, which is 6. I remember it EVM because I remember that it's 4, 5, 6, and the total is 15. The worst anyone can get is 3, and the best is 15. So eyes, open spontaneously is 4, to sound is 3, to pressure is 2, and no eye opening is 1. Verbal, so you assess the patient's verbal replies to you. If the patient's oriented, 5, confused, 4, mumbles words, then it's 3, and then just mumbling sounds, it's 2, and then if there's no response, it's 1. Motor, we have obeys commands is 6, localizing, meaning that they can tell you where the pain is by pointing to where you pinch or touch. Normal flexion is 4, abnormal flexion is 3, abnormal extension or extension is 2, and none is 1. So you notice that none in each one of these is 1. So the lowest score they can get is a 3. Now, what's abnormal flexion and what's abnormal extension? Or what's abnormal flexion and what's extension? Typically, yes. So one of your colleagues is asking a question: if a patient scores less than 8, is it an indication for intubation? Typically, it says GCS less than 8, intubate, typically. So that makes it easier to remember. Now back to the question. So abnormal flexion, what's this? And what's extension? How do we know which one's which? So abnormal flexion is the decorticate, and the extension is the decerebrate. How do we know? The first one is the abnormal flexion. You can see flexed, flexed, and both upper extremities are flexed. This is an abnormal flexion. And then extension, you can see the upper extremities and the lower extremities are extremely hyperextended. And this tells you what score it is just by looking at the patient. Typically, these two happen when you have a severe traumatic brain injury. Best score you can get, we mentioned this, is 15. The worst score you can get is 3. And then anyone with a GCS of 8 or less, typically they need to be intubated. So what are some things that may not, that this may not apply to? So if it's a non-trauma case and the patient comes in with, let's say, an opioid overdose and is basically has a GCS of 6 or 7 or 8, do you intubate them? No, you give them Narcan and then they wake up. So this is one of the exclusions to this. So it's not a one-size-fits-all type of thing, but in trauma patients, generally, this is one of the rules: is GCS 8 or less, then you intubate. Exposure and environment: complete exposure of the patient. Make sure that you maintain their temperature. So make sure that they're not a trauma patient in extreme hot conditions or extreme cold conditions. Make sure that when you actually expose the patient to see all of the injuries and do a full examination, that you keep them warm by covering them with a blanket, especially in children, because they lose their heat very quickly. So what are the adjuncts to the primary survey? Bye. CT scan is not an adjunct to the primary survey. They're adjuncts. They're simple things. So continuous cardiac monitoring, pulse oxy, vent rate, capnography, ABG. You want to log roll the patient. You want to make sure that you log roll them so you can check the back for any injuries. You want to make sure that the patient gets a urinary catheter, so a Foley cath, a gastric catheter, meaning an OG tube or an NG tube if needed. You want to make sure that the patient gets the X-ray if needed, portable X-rays, obviously, and then FAST, EFAST, and/or DPL. We won't get into the DPL, but the FAST very quickly. These are the FAST views. So this is the EFAST, meaning the extended FAST, which adds the lungs to the views as well. So 1, what's this? So this is the subcostal view where you look at the heart. 2, right upper quadrant. 3, left upper quadrant. 4, you look at the pelvis. And then the extension is 5 and 6, where you look at the thorax and make sure that the patient doesn't have any pneumothorax by lack of sliding. Bye. When do we transfer the patient? So we want to make sure that we determine the need to transfer the patient early, so we don't delay the patient's care, especially not to delay for testing. So let's say a patient comes in with a severe burn, and the patient needs a burn center and doesn't have any other obvious injuries. Do I keep testing the patient for other injuries? Do I keep them in my emergency department or in my hospital for a long period of time before sending them to a burn unit in another hospital? No, obviously not. Do I need to transfer them to a trauma center? Just as the example that I told you. Do I need to send them to a pediatrics trauma center? So did this pediatric trauma patient come to my hospital, but I don't have pediatrics admission capabilities or a PICU or pediatrics trauma team or pediatric surgeon, so I need to send them to a hospital? Is the patient someone who requires neurosurgical intervention in a hospital when I'm in a hospital that doesn't have any neurosurgical intervention? So these things I need to decide early in, not to delay the care of the patient. Some things to keep in mind: special population. We talked about 2 of these, which is the pediatrics and the pregnant ladies, which as someone who requires OB assessment, maybe monitoring. So yes, if they have signs of IVC compression, fetal injury, vaginal bleeding, these all need to be assessed for by an obstetric consultant. Now, pediatrics, we talked about them. They have different injury patterns. Sometimes they have normal vital signs for a long period of time before they crash, just because they have good compensation mechanisms early on in life. And then elderly. So elderly, we talked about the scalp injuries. So they have frail skin, They have easily breakable bones just because they have the frail bones. And we need to make sure that we understand what medications they're on, because sometimes the patient can be hypovolemic, just for an example, and is supposed to be tachycardic, but the patient's on a beta blocker. And if they're on a beta blocker and their heart rate is normally around 50, then a heart rate of 80 for them is tachycardia. So we need to keep these into consideration. We talked about all of these. Another part of the special populations is the morbidly obese patients, just because of the difficulty with their ventilation, just because they lose their reserve very fast. So if you want to intubate, let's say, a very obese patient, then the positioning is different. And then we have to keep in mind that they lose their oxygenation extremely quickly. So they desat than a normal adult. Athletes is just to know when, again, just like the elderly who's on a beta blocker, you want to make sure that an extremely conditioned athlete who has a resting heart rate of 40 comes in with hypovolemia due to blood loss, due to a trauma, they will not have a heart rate of 150. They'll show sometimes just an upper normal heart rate of 80 or 90, just because their heart is very well conditioned. So we have to keep these in mind. Okay. So next steps. We want to make sure to repeat the primary survey if there's any deterioration in the patient's status. So if any changes, then you need to actually go back and do a primary survey once more. With the same rule, you don't go from one to the other until you've secured the first. What's the secondary survey? It's a head-to-toe examination. Very simple. Head-to-toe examination. You examine everything. You don't want to miss anything. I've worked in places where they have a tertiary survey that has to be done by someone other than someone who did the secondary survey, just to make sure that we have fresh eyes seeing the patient, to make sure that we don't miss anything. Because a lot of times, especially in complicated trauma patients, you can easily miss injuries, especially the smaller injuries, because you're focusing on the other ones. So complete detailed head-to-toe examination. What's the ample history? Do we know what this is? Okay, allergy, that's the A. Medications, okay. Okay, I won't waste time. So allergies, medications, past medical history, last meal. Last meal used to be thought that it's important because of when you want to intubate the patient and the risk of vomiting and aspiration, but I don't think it matters as much nowadays. It's still good to know, just in case they need to go to the OR. And then events surrounding the injury. So what happened? What's the status? You want to get as much information as you can, whether it's from the patient itself or from the EMS team, the emergency medical services, the paramedics who brought the patient to you. Okay, so the secondary survey head-to-toe examination, you want to do a complete head examination, make sure that you don't miss any cuts, you don't miss any signs of depressed skull fracture, let's say. You want to make sure that the patient doesn't have any hidden signs. Maxillofacial, you want to make sure that the patient doesn't have any tenderness, no bruising, no signs of fractures. Cervical spine and neck, again, you want to make sure that the patient doesn't have any signs of cervical spine or neck injuries. Chest, we've went over. Abdomen, complete abdominal exam. You want to make sure that the patient doesn't have any, let's say, bruising, seatbelt sign, some things that you missed on the tender ribs, maybe something decreased air entry. You want to make sure that you don't miss anything that may have been missed in the primary survey. Same thing for the abdomen. Does the patient have any tenderness, any swelling, any developing bruising, so on and so forth. And then the MSK, perineum, rectum, vagina, pelvis, and neurological examination. These are all dependent on what the severity of the injury is. Head exam, inspection, eyes, ears, nose. So you want to make sure that you do a complete head and ENT examination, because there are a lot of injuries that you can miss. What's this? So the eyes, you want to examine, you want to make sure that the patient has a normal visual acuity, papillary size, no hemorrhage in the conjunctiva, no penetrating injuries, no contact lenses. So if the patient has contact lenses, you want to remove them before. If the patient has dislocation of the lens, like we see here, and or ocular entrapment. Ocular entrapment are entrapment syndromes because of usually facial bone fractures that lead to entrapment of the muscles or the muscle insertion site. So the patient can't do the full extraocular movements. That's entrapment. Okay. So these are normal pupils on the top, dilated pupils, and then you have aniscoria, which is one is dilated and one is not. So it's an abnormal response that tells you that there may be something that's affecting the optic nerve. What's this? Conjunctival hemorrhage. What's this? So this is globe rupture. You have a penetrating injury. What's this? We just talked about this. So this is one of the entrapment. So the patient can lift his eye up here, but this is the injured area, and you can see it's injured here. So the ocular muscles are entrapped, so the patient can't lift his eye up, so he can't look up. What's this? Come on. لا واضح اني بجيب لكم اسئله محترمه في الاختبار عن التراما. خليكم تصحصحون شوي. شكرا باسل. اي eardrum. وش فيها eardrum؟ So this is hemotympanum. Hemotympanum, yes, thank you. There's blood behind the tympanic membrane. So this is the tympanic membrane. You can see it's very bruised. Why is it bruised? Because there's blood immediately behind it. So what does this give us an indication of? Yes, base of skull fracture. Good. Okay. What's this? So this is bruising behind the ear. This is called Battles sign, Battles, Battles sign. This also gives you an indication that there's a skull base fracture. What's this? شكرا يوسف. كل شيء قاعدين نتكلم عنه تراما. أكيد تراما. What is it? So this is blood on the cartilage itself. What's this injury? The significance of this injury is if you don't actually incise and drain, usually done by ENT, then you can get a cauliflower ear. Cauliflower ear is something that you typically see in boxers. Yeah, it's a hematoma. So you need to drain it because it's on cartilage. and it can decrease the blood supply just because of compression. So you need to drain it and then put pressure dressings on it so we don't get a cauliflower ear. I don't think I have a picture of cauliflower ear, but cauliflower ear is basically the ear itself basically crumbles on itself and it looks like a cauliflower and it looks ugly. You can see it in the boxers who don't get their ears drained post fights. Typically, that's where you see them. Boxers or UFC fighters, yes, boxing gear. طيب, what's this? These are all things just to show you the importance of a complete head examination, including eyes and neck, ENT examination. It's very important. Yes, this is nasal septal hematoma. Same thing that applies to the ear applies here. It's a very thin septum in the middle. So if you have compression from this, what can it do? It can lead to fibrosis and it can lead to even what's the word I'm looking for? Penetration of the nasal septum itself. Okay, maxillofacial. I won't get into too many details about this, but inspection, palpation, the usual. And then you want to do an intraoral examination. You want to make sure that there are no injuries. Sometimes you can have evidence of a large hematoma in the intraoral pharynx. This, if it's rapidly expanding, then can cause one to have obstruction of the airway. So it's very important to see if you have any occlusion issues with the bite. So you want to make sure that the patient doesn't have any issues with being able to maintain their nutrition because they can't bite down. Very normal nose, no fracture at all, sir. So this is one of the things that you can actually just see by inspection. This is an excellent picture of things that you can pick up by inspection. Typically, these are picked up on the primary survey, and they're bigger injuries, but you still want to make sure that these are not missed, not documented. This is just the type of fractures that you can get with the maxillofacial. This is the simple fracture. This is a little bit more complicated because it involves both maxilla and it goes, this whole portion in the middle, you can actually pull out. Same thing applies here. These are very dangerous and they need to be fixed by a plastic surgeon or a maxillofacial surgeon. Okay. What's this? يا رجل تعوذ من إبليس. Fracture.
Raccoon eyes.
أيوة, raccoon eyes. شكرا. شكرا. طيب, what's the significance of raccoon eyes? You guys mentioned this before. So raccoon eyes can give you an indication that there's
a fracture.
Fracture, yes. Okay. Moving on to cervical spine and neck. So any patient who actually with head or maxillofacial injuries should have a presumption that there's a C-spine injury until proven otherwise. طيب. How do we do a complete neck examination? Basically, the first thing we do is we maintain C-spine immobilization at all times until we make sure that the patient has no tenderness, and then we make sure that the patient is able to move their neck. Again, this is not something that you'll be doing on a regular basis, you for yourself at this level, I mean, but still something good to know. Imaging is the next step for those who don't meet the criteria for being cleared clinically. And we'll talk about this with the spine and with the spine injuries. We'll talk about some of the rules that you can use. Inspection, palpation, auscultation, things that you can do when there's a suspicion of a vascular injury. Neck hematomas are very bad because they can lead to obstructing airways, and then they can lead to hypovolemia as well. So we want to make sure that the patient doesn't have any bruits, no cervical spine tenderness, no subcutaneous emphysema, no tracheal deviation. Even laryngeal fractures, which are dangerous, can be discovered just by palpation on itself. This is why it has to have a very detailed examination as a part of the secondary survey. All head-to-toe examination on the secondary survey after initial stabilization of the patient is very important. You have no idea the number of things that can be missed on a primary survey. There are lots of things that are not picked up on the primary survey that are picked up on the secondary survey. And even then, you can still miss a few injuries and pick them up later on a tertiary survey if your center has a tertiary survey. And I recommend, if anyone's going into surgery or trauma and is going to do emergency medicine, who's going to deal with these patients, you may not be able to do a tertiary survey as a part of emergency medicine. But if you're in these surgical specialties or an ICU that deals with these patients, even if it's not a part of the protocol that you guys have, please do it, because you'll still pick up injuries. I did a mini fellowship in trauma, and the number of things that we pick up on the tertiary surveys, not even the secondary surveys, because the secondary survey was done very quickly, are unbelievable. You can pick up a whole lot of injuries that, and even significant injuries that may alter the patient's quality of life or cause mesis, such as the ear hematomas or the nasal septal hematoma or the or simple hand fractures that you can find. We've picked up lower extremity fractures that didn't show up just because they were minor, and we had more severe injuries that we focused on. So it's very important to do a detailed examination. We've talked about this. So this is why it's important to take a look at patients very closely. This is a very small stab wound. If the patient has multiple other stab wounds and we don't do a complete examination, we could have missed this very important and potentially life-threatening stab wound to the neck. Okay, chest, we've talked about inspection, palpation, auscultation. You want to make sure that you actually do the inspection and the palpation anteriorly and posteriorly. Remember that the chest is still also in the back. So we want to make sure that there's no swelling, no bruising, no abrasions, lacerations, any flail segments, seatbelt sign like we talked about. We want to make sure that we palpate for fracture, including the sternum, the clavicles. We want to make sure that there's no subcutaneous emphysema. And then on auscultation, we want to make sure that the lungs and heart are clear. Abdomen pelvis, inspection, palpation. We mentioned the seatbelt sign before. This is why we want to inspect, palpation for any tenderness. And then what's this? اللي بيقول لي trauma يعني بينزل عليه، بينحط ميوت إلى الأبد. What is this? طيب, at least start by describing this. So this is a shortened right lower extremity compared to the left. It's internally rotated. So this typically gives us that there's an indication that there's likely a femur fracture or a posterior posterior hip dislocation. طيب. Perineum, rectum, vagina, inspection, palpation. We want to make sure we do a digital rectal examination, which is what the DRE stands for, if indicated. Musculoskeletal, you have to go through every single joint, including the pelvis, obviously, and then the skin. Neurological exam, you want to do a full neurological exam if the patient allows it. So After the secondary survey, what do we do? What are the next steps? We want to make sure that we continuously reevaluate the patient not to miss any overlooked injuries, like we mentioned before. We want to transfer the patient to definitive care, whether this is inside the hospital, let's say to the ICU if needed, or to the orthopedic surgery if it's an isolated ortho injury, or for trauma team if it's a hospital that has a trauma service that admits, and so on. Or is this a patient that requires transfer for, let's say, a burn unit or pediatrics or an OB-GYN center, so on and so forth. Conclusion, want to always be prepared. Primary survey with the adjuncts, continuous reevaluation. Repeat the primary survey if any change in the patient's clinical status. Repeat. Detailed secondary survey with the adjuncts along with the reevaluation, and then reevaluation at the end with definitive care. I would say the planning to transfer the patient, if it's indicated, would happen after, if not during, the primary survey. Frequent reassessments. Always keep a high index of suspicion for injuries, especially if the patient has a change in clinical status. Any questions about this? ما أقدر أشوفكم فبعدل 3. Any questions? 1 2. وش فيها البيلت ماركس؟ هذا مو بسؤال. Seat belt. It's called seat belt sign. So الاسم الثاني للبيلت ماركس هو seat belt sign. That's the actual name. غيره. بعدل 3 مرة ثانية. 1 2 3. ممتاز. طيب يعطيكم العافية. خلونا ناخذ 5 minutes ونبدأ 9:15. كم الساعة الحين بالضبط؟ لحظة.